Welcome, ladies and gentlemen, to Treating Peripheral Arterial Disease, How to Generate Better Patient Outcomes Through Early Detection. My name is Dr. John Martin. I'm a vascular surgeon, and I'm happy to present this to you today. This presentation is hosted by Biomedics. I want to apologize up front to folks. I have to be in New York City today for a meeting, so sitting in the city, you may hear some sirens in the background, some traffic noise. That's pretty typical for New York, for those of you that know the city. I don't think it should get in the way of what we're trying to share today, but I wanted to apologize to you up front for that. The reason we're bringing you these webinars this month is because this is PAD month, Peripheral Arterial Disease. So let's start with what exactly is peripheral arterial disease. Well, peripheral arterial disease comes by many names. Often you'll hear it as atherosclerosis, hardening of the arteries. And what it is a buildup of plaque in the arterial wall of vessels supplying the legs and the arms. That disease, that atherosclerosis, is similar to what causes coronary artery disease, carotid artery occlusive disease, and can affect the arteries to any distribution in the body. This plaque is made up of cholesterol and calcium, and as the plaque builds up, once it compromises more than 50% of the lumen of the artery, it begins to impede flow to that area. This leads to lack of oxygenated blood to the lower extremities with PAD, and the more severe the blockage, the more oxygen-starved the tissue becomes, and then you get more progressive symptoms. And we're going to walk through what those symptoms are, how we can diagnose it, what treatments are out there for it, and why it makes such a big difference to actually pay attention to this. So why is this significant? Let's start with what the dreadful outcomes of unmanaged peripheral arterial disease is. There are 185,000 amputations performed each year in the United States. And that has led to over 2 million people living with an amputation in this country alone. Over 50% of those are due to vascular disease. And over half of the people who have had an amputation of a leg will have an amputation of the second leg within 3 years. And half of the people who have an amputation will be dead within 5 years. As you can see, this is a dreadful byproduct of an aggressive disease, and one that clearly screams for early detection, early intervention, and maybe even more importantly, prevention. 85% of amputations of the lower extremity for non-traumatic reasons are preceded by an ulcer on the foot. That basically tells us there's an early warning sign of bad things to come, and we have an opportunity to change the ultimate outcome. Not only does this create an incredible medical burden on people and social impact, it has a tremendous economic burden to the country itself. The United States alone, $319 billion is spent on the management of PAD, which dwarfs diabetes, coronary artery disease, and cancer. This is an economic killer to our healthcare system in the United States. And if you look at the average Medicare beneficiary, as we move toward capitated payments for Medicare beneficiaries, the typical Medicare Advantage plan, the average expenditure for a patient is $11,000 a year. But if you put PAD in one of these patients, you're now talking about 7 times that amount, or $72,000 a year. As you can see, this can actually break the bank. Now, how often is this a problem? Well, if you look across the United States and look at some of these important risk factors, 30% of patients over the age of 50 with diabetes have peripheral arterial disease. 30% of smokers over the age of 50 have peripheral arterial disease. And all patients over the age of 70, 1 out of 3 of those that walk through the door into your office have PAD. And I promise you, we are not making this diagnosis that often. What are the risk factors for PAD? There are certainly those that accelerate the risk and those that should attract your attention to be diligent about making this diagnosis. Age, as we demonstrated before, 30% of people over the age of 70 have PAD. 20% of people over the age of 40 with diabetes have PAD. So the older you are, the more likely you are to have PAD. Smoking, high blood pressure, high cholesterol, and diabetes are what we call the big 4. Each one of these raises the risk of peripheral arterial disease. Each one doubles the risk of PAD alone. So if you have all 4, you have 16 times the risk of having peripheral arterial disease. You also look at patients that have diabetes. It accelerates the development of PAD by a decade. So this is a critically important thing to see. If you see people with diabetes, it is really important that you recognize that PAD is a high risk. Diabetes has grown systemically tremendously across the United States, and I want to walk with you this progression. In 1995, by color coding, you can see that about in a few of the states across the country, 4.5% to 5% of adults were diagnosed with diabetes. Follow me through these years. 2005, a decade later, you see the colors have dramatically changed, with now a significant number of states going above 9% having diabetes. 2015, the country is turning red, where you see almost 2/3 of the country, greater than 9% of the population, have diabetes mellitus in these states. So if you look at this, what are the percentage of US population and graphed it out with diabetes, you can see this curve is on an exponential growth. This is, excuse me, this is not a great trend. And as you can imagine, with the growth of diabetes comes the acceleration of peripheral arterial disease, and the more frequent this diagnosis is going to be made. And what is it? Why has there been such a tremendous growth in diabetes across this country? It is directly related to obesity. In this country, body weight and adult onset diabetes are directly related. And as you look at these two graphs, you can see they're almost mirror images of one another. Weight and diabetes are directly related. So as the country faces this crisis in obesity, diabetes is riding in that same car right along with it. And with it follows peripheral arterial disease, now more common and then earlier. And I will tell you as a vascular surgeon, significantly more difficult to treat. So if we recognize the fact that PAD is common, and we certainly know which risk factors that should raise our index of suspicion, what are the symptoms of patients with peripheral arterial disease? Well, sadly, over 50% of them are asymptomatic. Part of that is because they're typically not an active population, or the disease hasn't gotten to the point yet where it's inhibiting blood flow significantly to the extremities to cause complications. But once that progression gets significant, the next level of symptoms is something called claudication. And that is the exercise-induced pain in the muscle groups of the legs. That can involve the hips, thighs, or calves. It typically occurs at very reproducible distances. So patients will say to you, I can walk halfway down the block and I have to stop because of pain. I rest for a little bit, then I can start again. But it happens at the same distance every single time. If when you're gathering a history on a patient and you hear that, the antenna should go up in your ears. I'm probably dealing with a patient with PAD, because arthritis pain does not act that way. Sciatica doesn't act that way. It's a very characteristic symptom of PAD. What you're doing is stressing the muscles, and that stress to the muscles, once it exceeds the ability of the body to deliver oxygen, that's when pain occurs due to anaerobic metabolism, if you dig back to our medical school days. Once the disease continues to progress, the pain then develops at rest. We're not delivering enough oxygen for the tissues even at rest. And I'll show you a characteristic way you can identify a patient with rest pain. Continue the progression, it gets even worse. The skin starts to break down and ulcers form. And finally, the end result of severe PAD and the lack of oxygen to tissue is tissue necrosis or gangrene. And unfortunately, sadly, too often we see this in our practice. So if you look at this from a pictorial perspective, the typical progression, first asymptomatic, then claudication, and the calves are a very typical location on the top left. The next step is rest pain, and what you'll see in patients that have rest pain is they hang their legs off the end of the bed. You'll see this patient resting in bed, sleeping, but they have their legs pushed between the bars of the bed so they can hang it down. They're using gravity to try to deliver more blood flow to the feet to relieve the pain at rest. Very classic. You walk into a patient's room, you see this, that's rest pain until proven otherwise. Then you continue on the top right, an ischemic ulcer, and ultimately the worst case scenario, gangrene, where there's no hope of saving this tissue. What we want to do is catch these patients even before they have claudication, when they have the earliest forms of disease, so we can intervene. You have to start with every patient a physical examination, and you want to start with the feet, a very important place to look. You look for foot deformities, plantar flexion of the metatarsal head, Charcot deformities and calluses. All of these are characteristic of patients with diabetes. With diabetes, you get peripheral neuropathy. With peripheral neuropathy, you get motor, sensory, and autonomic changes. Those motor and sensory changes lead to classic deformities of the foot, which change the loading forces and cause the pressure of the foot to be listed over top of the metatarsal heads. This creates calluses that ultimately lead to ulceration. So careful physical exam of the feet is important, including looking between the web spaces for ulcers, looking for skin changes like a loss of hair or thinning of the skin, color changes, temperature changes. All of those are critically important. So as we talked about, dermatologic assessment, not something typically I paid a lot of attention to in my early residency days, but I've come to really appreciate how important a careful dermatologic exam can be. So it's the absence of hair growing on the foot, one of the earliest signs of vascular disease, changes in skin texture, interdigit ulcers, cool feet compared to, say, the other side or more proximal leg. And certainly you want to look for those color changes in the skin. All of those things are warning signs that you're dealing with either neuropathy, vascular disease, or both. So neuropathy, the neurologic assessment of feet in the diabetics particularly, is critically important. It's important because those atrophic changes in the autonomic system leads the skin to get dry and crack, and ulceration is much more likely to form, and it can help introduce bacteria into the skin. And unfortunately, they can't feel their feet. So ulcers will form and they have no idea they're there. It is not uncommon for someone who has poor eyesight due to diabetic retinopathy and peripheral neuropathy can't feel their feet, that they could develop an ulcer on the foot that they have no idea is there. They never see it. So it's really important that we become their protective mechanism and look at their feet carefully and measure whether or not they have normal reception or sensation in their foot. So why is a comprehensive foot evaluation so important? Because ulcers don't necessarily form on the skin first. What happens is in patients, particularly with diabetes, is they get the diabetic neuropathy or a clawed deformity of the foot. This leads to the loading forces being over top of the metatarsal head. That forms calluses on the bottom of the feet. And as you examine feet often, you'll know you've seen those. That callus is really hard. The metatarsal head is hard. And what happens is it crushes the tissue in between. So the ulcer forms from the inside out. So the last manifestation of this problem is the development of the ulcer all the way through to the skin. You want to intercede on these situations when the callus is forming, make the skin soft, put people in the right footwear to prevent the ulcer from ever forming. So a comprehensive foot evaluation is critical to prevent ulcer formation of the foot. So one of the things I always want to leave you with, and every time I talk about peripheral arterial disease, this is a critical component, and that is, as good as we believe our diagnostic acumen is, physical examination is not enough. Pulse examinations are difficult. It may be the most unreliable piece of information on a history and physical. The problem is we feel our own pulses. It's hard to really judge. What's a normal pulse? What's a low pulse? What does it matter if I have a really good posterior tibial pulse but no dorsalis pedis pulse? What does that mean? So pulse examination can be incredibly unreliable. We need a more objective way to measure perfusion in these high-risk patients. We're used to looking at the dorsalis pedis on the bottom, the posterior tib on the top. Sometimes both are not there. Sometimes we're feeling our own pulse, so it's not accurate. Most of you are familiar with ankle brachial index, a blood pressure cuff around your ankle, one around the arm, and we know that the pressure in the foot should be slightly higher than the pressure in the arm. Unfortunately, ABIs are not always reliable, particularly when the vessels are calcified. You try to squeeze a calcified artery, they can't be squeezed. You'll see pressures are really, really high because you never lose that pulse signal. Unfortunately, there can be very significant peripheral arterial disease in that setting. Some of you may not be familiar with pulse volume recordings, or PVRs. This measures changes in pressure used by air plethysmography that reflects the arterial waveform. So as the arterial wave moves through the leg, it depresses the air inside the cuff, and under normal circumstances, you get a nice dicrotic notch and waveform. But as the severity of vascular disease progresses, you will see the waveform changes. and this is predictive of the severity of disease. Now, there are a number of different factors that can affect the accuracy of PVRs, but this is a very valuable tool with a test that's easy to perform that can add to just a simple physical examination. And one of the things I like to do to make it a very simple, fast test is just do the PVRs at the ankle level with a simple cuff. Your medical assistants can do this. That'll give you a quick guide. If you see an abnormality, a more formal test can be performed. So remember, ABIs may be insufficient, PVRs, and typically toe pressure indexes can be important adjuncts to assess perfusion. If you look at this x-ray on the right, you can see a great outline of the superficial femoral and popliteal arteries. There's no contrast in this image. This is calcification of the entire artery, something we typically see in diabetes, and you can tell a blood pressure cuff around this blood vessel is not going to compress the artery. So PVR waveforms have kind of a characteristic pattern in this calcification, and certainly toe pressures, where the calcium doesn't necessarily affect the digital vessels, can give us an indication of the perfusion to the foot. So how do you select patients for testing? Well, look for your risk factors. If they are the right age or have multiple risk factors, then you should do careful physical examination and ankle PVRs. If the ankle PVRs are abnormal, go to a full arterial study, putting the cuffs at 3 different levels. That will help judge at what level the disease is located. Very important for us to screen these patients. Remember, over 50% are asymptomatic. Now, those test results, plus the patient's symptoms, their age, will guide our treatment decisions. So if you look at this, if the vessels are non-compressible, often you'll see an ABI greater than 1.4. You want more advanced testing and potentially refer them to a specialist. They may require just pharmacological interventions. If they're normal, you just want to monitor them and do good cardiovascular health recommendations. If they have mild disease, it's characterized by the waveforms being blunted. You don't see that nice dichrotic notch, and ABIs are diminished. You want to recommend lifestyle changes. These are supervised exercise programs, smoking cessation, nutrition, weight reduction. Clearly, this is important, and there are medications like aspirin and statins that are important. The more severe disease, whether it's moderate or severe, you'll start to see significant drops in the ankle brachial index if the vessel is compressible. Those patients may need more drastic interventions. Certainly, they need pharmacologic interventions with aspirin and statins if they can tolerate it, and many may need more aggressive interventions, whether that's balloon angioplasty, stenting, or bypass. These are the patients you want to refer to your vascular specialists so that you can share the diagnostic findings and make a plan together on what's the most appropriate treatment for the patient, considering comorbidities, age, and lifestyle. So a care delivery pathway is something that's really important to develop. And each one of these actually has coding that can go along with it. So this does not just need to be about a perfect quality of care. There is economic value in doing this. This is one of those really unique situations in medicine where the economic value and the patient value are matched. So patient consultation, you want to look at your patients from the beginning, our typical level 3, level 4, level 5 visit, depending on the complexity of the patient itself, and it should include evaluation of the skin and evaluation of their vascular supply, and you can do ankle PVRs. If they are normal, a regular follow-up based on their comorbidities. If they're abnormal, you should consider doing a full arterial study, and that CPT code is 93923, which you can bill for. And then you can have them back into your office to discuss them for a shorter visit, reevaluate, and make a treatment plan with them. If they have only mild disease, again, exercise, risk modification is important. Moderate to severe, you got to start thinking about pharmacologic interventions and referral to your specialist. Certainly as well, you want to pay careful attention to their footwear. Diabetic shoes are critically important in these patients if they have foot deformities, if you want to prevent ulceration. This care delivery pathway is unique for every patient, but follows general guidelines based on the severity of their disease. Now I want to pause for a moment and share with you a little bit of my personal experience and how I've changed my practice over time. I will candidly admit, as a vascular surgeon coming out of a great program, I prided myself as being able to completely take care of the patient myself. I didn't need any help from anybody. And when I finished, I knew a lot about the diabetes medications at the time, the hypertensive meds. And while the primary care doctors were around, I had no bones about changing any of the medications if I thought it was appropriate. Well, medicines change. I've gotten smarter, and we've all gotten better on how to get better outcomes. And now I can tell you I depend dramatically on a whole host of people that I never depended on before. So the primary care physicians manage their medications. I certainly know that diabetes management has gotten far more complex, and I'm not the expert anymore. Neither am I the expert in hypertensive management. The endocrinologists for those complex diabetes play a critical role. But probably one worth speaking about a lot are the podiatrists. I did all of my own digital amputations when I started. Then I came across a podiatrist when I went into private practice, saw some of his amputations, and candidly, he did a better job than I did. So I started referring those digital amputations to him. We started working together, and I noted those patients in whom were referred to me first, who weren't wearing the right kind of shoes, who didn't get the right kind of foot care, were not getting as good outcomes as those that were involved with my podiatrist. So they became a critical part of my care community. The same thing with cardiologists and orthopedic surgeons. So when you look at this patient group, particularly the elderly that have multiple risk factors, there are a number of different experts in different disciplines that if you engage all of them and communicate together, you will get significantly better outcomes in the management of your patients. It is important that you get to know these people, that you work together, particularly in light of the fact that many of us don't meet together inside the hospital anymore as we once did. So I strongly encourage you to develop a community of physicians that will work with you on these patients. Now let's talk a little bit about lifestyle modifications. And whether you're a podiatrist, a vascular surgeon, or internal medicine family practice doctor, we all should be engaged in encouraging our patients to do the same thing. And these are typical for all patients, but most appropriate if we want to get to these patients at the earliest stages of disease where we can prevent progression. Studies have certainly shown that you can identify PAD, really tell your patients what problems they have and what they're looking to them in the future. You can get them to modify their behavior. So lifestyle modifications are critically important, and you'll have experts in your community that can help you. The biggest one is smoking cessation. There are smoking cessation programs, certainly consultation in your office. If you spend greater than 3 minutes up to 10 minutes talking about that, and you should, there's a billing code for that. And certainly more than 10 minutes, there's a second code for this. This should be a regular part of your discussion with your patients, and they come to see you if they're actively smoking. And I encourage you to find smoking cessation programs in your community. The second thing is nutrition. We certainly know lean meats and vegetables, low fats, appropriate diet and weight reduction are a critical part of long-term success and health. Dietary counseling is another one of those things that's important to document, including the time you spent, the discussions you've had. You really want to influence our patients to do things differently. Finally, the new arrival on the scene is the supervised exercise therapy. For you primary care physicians and cardiologists, you're familiar with cardiac rehab. It's been around for quite some time. It's reimbursed. It's a hallmark of patients that have had a myocardial infarction. Well, finally, Medicare has caught up to the data. We know that supervised exercise can have a dramatic impact on both the quality of life and outcome of patients if it's done. And so now in 2018, there's a new code, 93668. You can have 36 sessions over 12 weeks, and this can be paid for. It must be delivered by qualified personnel, but your patients themselves can attend this and bill Medicare for it. So this service is now growing rapidly across the country. I strongly recommend that if you don't have this program in your area, try to encourage someone to start it, because it will have a positive impact on your patients. The last thing to think about here is pharmacologic interventions. Now, you may not be the one actually prescribing these medications, but you want to bring it up. All of us could use the help from each other. If someone has PAD and they're not on an aspirin and a statin, you got to ask yourself why. There may be a good reason, but at least challenge the notion. Maybe someone hasn't made the diagnosis before you. Maybe someone hasn't thought of it. Maybe the patient has forgotten that they were supposed to take it. Certainly, blood pressure control is critically important. And for those patients that have intermittent claudication, there is a medication, slostazole, that will help 50% of patients walk farther. It is a critical part of my care delivery pathway for claudication patients before I consider intervention. And finally, obviously, lowering patients' hemoglobin A1C, long-term diabetes control is a critical part of success. So before I leave this, again, I want to reiterate one fact, and that is all of this sounds like, oh my gosh, it's a lot of work to do all these things. Can I fit it in my busy day? Those days when you have 20, 25, 30, maybe 35 patients, how do you fit all this in? And this is part of building this into your entire team's practice. Everyone can ask the questions. You can divide and conquer which tests are being performed. Your MA can learn how to do these vascular tests. You can certainly talk to your patients while you're examining them, but it's a critical part of this. But if you include these elements into your practice, there is revenue associated with it, and that's increased payment for vascular assessments, office visits to follow up on those visits, and if you're a podiatrist, certainly sales of shoes and footwear are critically important. You can use the same staff, the same patients, and increased revenue to support this activity. So I would encourage you to get to know the coding rules, alter your practice. It is one of those things that's better for the patient, and it's better for your practice, and it's better for healthcare in general. So let me leave you with these final notes. Number one, clinical examination alone is not sufficient for PAD. You need to do additional testing. You will miss patients if you go by just physical examination alone. And PAD screening and intervention can reduce mortality by 65%. That's a pretty big number. They can prevent amputations, and certainly if you prevent amputations, you reduce mortality. Screening and awareness of PAD can motivate healthier behavior, and collaborative care, working with your partners in cross disciplines, reduces overall health system costs. This is PAD Awareness Month. Our goal is to reduce amputations across the country, catch vascular disease earlier in its course of development, and if we do those things, we will see long-term benefit for the system, for your practice, and for your patient. So I can open up the door for questions. You can see there's a Q&A box here on your screen. If you'd like to ask some questions, feel free to type them in. I'm happy to answer them. I would encourage you that if evaluation of PAD is not a regular part of your practice, please consider adding it, and certainly take some time to get to know your vascular specialists in the region and those others that can work with you. If there are no additional questions, I want to thank you all, and I want to thank Biomedics for giving us the opportunity to share this information. Again, PAD Awareness Month. I'm sure there are patients that have come in and out of your office where this diagnosis hasn't been made. This certainly was the case in mine, and this increased awareness will make a huge difference in their lives. Thank you again for participating with us today.